Welcome to the Nursing Post podcast, all nursing all the time with Ashley Moore and Rosa Horsley. This month is Prematurity Awareness Month, with November 17th being Prematurity Awareness Day. We will be discussing premature births and maternal deaths in this episode. Our goal is always to inform and to start conversation.
About 700 women die every year in the United States as a result of pregnancy or a delivery-related complication. According to the CDC, a pregnancy-related death is defined as a death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the psychological effects of pregnancy.
Statistics, as always, because we love our numbers. In 2018, there were 17.4 maternal deaths per 1,100 live births in the United States. Maternal death rates among women 40 and older was 81.9 deaths per 100,000 live births, and almost 8 times the number for women under 25.
So a huge jump at the age of 40 for your risk of maternal death.
Yeah, that's a big jump. 60% of pregnancy-related deaths are preventable without much cost, but the number has not gone down. Maternal deaths are a hard group to study because it's rare, roughly 1 to 2 per every 10,000 births. Heart disease and stroke cause more than 1 in 3 pregnancy-related deaths between 2011 and 2015 in the United States, and that's according to the CDC. The other leading causes of maternal death are infections and hemorrhages, which most nurses know that a hemorrhage is a severe bleed.
There are some risk factors for premature births that we'd like to talk about. This topic is a little bit kind of close to our heart.
Mm-hmm.
I had a premature child.
Yes, and I had 2
and
that
you
were
had
premature.
2. And so it kind of, I guess, hit a little bit close to home, which is why we wanted to do this. And hopefully we won't keep you for too long on this podcast. But for premature births, age is a factor. So if you're younger than 17 or older than 35, your risk for premature birth goes up. If there's less than 18 months between pregnancies, if you smoke, drink alcohol, use illegal drugs, or abuse prescription drugs, your risk goes up. If you have a very stressful life, that also can impact it. If you have low socioeconomic status, that is a risk factor. Mainly because a lot of those patients are not getting proper care.
Mm-hmm.
Domestic violence, if you work long hours or have to stand a lot, and exposure to either air pollution, lead, radiation, or chemicals.
There are also other medical risk factors during pregnancy, medical conditions that maybe you had prior to even being pregnant. And then some that maybe you've had in the past before. So if you've delivered a premature baby in the past, that heightens your risk of your next pregnancy being a premature birth. If you're pregnant with multiples, twins, triplets, quadruplets, sixlets, I lose count after that. Problems with your uterus or cervix now, or you've had them in the past. Additionally, pregnancy complications can result in preterm birth because the baby has to be delivered early. So sometimes it's not even like a complication with the mother. Maybe it's a complication or a risk with the baby itself.
Right.
Being underweight or being overweight, that heightens your risk factor. If you have an eating disorder, whether you're anorexic or bulimic or you binge eat,
right,
that has risk factors associated with premature births. If you have a family history of it, that means someone in your immediate family has had premature births. Maybe you were born premature.
Right.
That heightens your risk of having a child that's premature. Connective tissue disorders have a higher likelihood of having premature births, and other genetic conditions. Diabetes, high blood pressure, infections, including sexually transmitted infections, having a UTI, or, an infection that's vaginal or uteral gives you a higher risk. Intrahepatic cholestasis of pregnancy, also called ICP, is the most common liver condition that happens during pregnancy. And thrombophlebitis is a condition that increases your risk of making abnormal blood clots. Also, getting no or late prenatal care heightens your risk of premature delivery. Bleeding vaginally in your second or third trimester. Having a preterm premature rupture of your membranes, so your water breaking before delivery, due date I should say. Being pregnant after in vitro fertilization. In vitro, anytime is going to be considered a high risk pregnancy.
Right.
It wasn't done naturally. You already had issues trying to get pregnant to begin with. So you're already at a high risk. And then, being pregnant with a baby who has birth defects.
Right.
And increases the chance of having a premature birth.
When we talk about premature birth, we're talking about you going into labor before 37 weeks. We know that a typical pregnancy is 40 weeks.
Mm-hmm.
So if you are going in any sooner than that, that's considered, preterm. There are many different reasons why you can go into preterm labor, but you can actually just go in kind of like regular labor. It's just too soon.
Mm-hmm.
So you'll start getting contractions about every 10 minutes or sooner. You can get a change in vaginal discharge or leaking. You can have pelvic pressure, low, dull back pain, cramping, and this is with or without diarrhea. It doesn't necessarily have to come with or without that.
Mm-hmm.
And then, of course, your water just breaking.
Premature births and preemies that are born sometimes have, conditions or complications that came from them being born early. So they might be anemic, have breathing problems, have apnea, have bronchopulmonary dysplasia, persistent pulmonary hypertension of the newborn. They can have pneumonia, have issues keeping warm, have respiratory distress syndrome. They can be bradycardic. They could have coarctation of the aorta, heart valve abnormalities, patent ductus arteriosus, septal defects, TOF, transposition of the great arteries, feeding difficulties, abdominal issues, hypoglycemia, intrauterine growth restriction, intraventricular hemorrhage. They could have jaundice, macrosomnia, necrotizing enterocolitis, retinopathy of prematurity, and sepsis. That is a long list.
It really is. And reading some of it, a lot of them go together.
Mm-hmm.
And you could see where one would compound the other. So we thought that we would go a little bit into our stories of our premature births. I'm going first because mine is much simpler than Rosa's. I love you, Rosa.
Really?
We already know that a preterm pregnancy is before, or preterm birth is before 37 weeks.
Mm-hmm.
And there's a couple of categories that the preterm birth goes into. You have extremely preterm, which is less than 28 weeks, very preterm, which is 28 to 32, and then moderate to late preterm, which is 32 to 37 weeks, which is where I landed. I had my son at about 34 weeks of age, close to 35, but that doesn't count in medicine. That placed me obviously in the moderate to late preterm. And we've gone over many reasons why you can go into premature labor. However, I did not have any of those issues. I had a prior pregnancy that was, I literally gave birth 2 days before my due date. So that was like right on point, no complications. I'm pretty straight-laced. I don't smoke. I don't really drink. None of that. Took my prenatal vitamins, did what I was supposed to do, did all my checkups. Everything was on point.
Mhm.
So I think it kind of surprised everybody when I went into preterm labor. At the time that I was working as a nurse in a long-term / skilled facility, I worked nights. And I had worked the previous night, got off at 7 in the morning, went home, went to bed. When my husband got home from work, my back was killing me. But I was pregnant and I worked as a nurse on nights. So,
on your feet, yeah.
I mean, it really didn't, it's like whatever. But as the night went on, my back kept hurting worse. And I'm like, oh my gosh, this child needs to move. He must be sitting on a nerve. Something must be right. So I'm trying to get into different positions, push to my stomach to try to get him to reposition. Nothing worked. And my husband's like, maybe you should just stay at home tonight and see if this checks up. And I was like, I really felt bad because I didn't want to call out. I'm not that kind of person. But I pondered on it for a while, and then I finally called, and I was just like, I talked to the DON. I was like, I just can't come in. Something's not right with my back. And she's like, you're about to go into labor, boo. I'm like, no, I'm nowhere near, being ready to go into labor. And she
was telling you different.
She was, and she told me she'd call me in a couple of days to check on me and the baby. We worked together for years. I had worked there as a CNA before I became an LPN, so I knew her very well, and she knew me. So she knew if I was calling out, something was wrong. Well, that night, of course, I left at 10 to get to work by 11, which I got there a little bit before, but you got to, get report, do all that good stuff. So I remember going to lay back down at the time that I really should have been wide awake. And I was like, oh, and so I laid down and I couldn't get comfortable, which is not really uncommon for most pregnancies, but with both of my pregnancies, I didn't wake up in the middle of the night to go pee. I didn't do all that.
God bless you.
Like,
How?
I went to bed. I didn't have a lot of that. So I was very, very lucky.
Strong bladder.
It's the nurse, I'm telling you. And so I was uncomfortable, so I got up to go pee. And of course, my husband looked at me like, what are you doing? I gotta pee.
Because you've never done that before.
Because it's not what I do. And I was just gushing blood. And so I was like, okay, that's not normal. So I just sat there for a second, and then I yelled at my husband to get me a pad and told him that we needed to go. Of course, it was snowing. It was beginning of January. He's not knowing what to do. I really wasn't having what I would call contractions. Looking back, that's probably where the back pain was. But I did not put the 2 and 2 together because it just wasn't time yet. So I got in the shower, kind of, washed up, got myself feeling better, got everything together, took my daughter to my mom's, told my husband we'll call, the doctor on call on the way up there. We did have a little bit of a drive. And when I called the OB, they're just very unimpressed because that's what they do all the time.
They've heard it before, I'm sure.
Like, yeah, you're coming in. We're going to do this whole thing. We're going to send you home. But she told me to come on in because I was bleeding. And so I got there and they checked me in. And on the way there, I did start actually having contractions, and they were about every 10 to 15 minutes. But I couldn't get up and walk around. So I didn't know, if it was real contractions or not, because that was kind of my thing. I'm like, oh, I just need to move and this will feel better. If I could just get up and move. But I was kind of in a car where I couldn't. And I get all together. They get me all hooked up. I tell them when I get there that I was, I'm the one that wants the epidural before we even get anywhere. I'm not being cute. I'm not trying to do this natural. Don't push any stuff in my IV because it ain't going to do anything but make me tired and in pain. So I just waited out. I'm that kind of person. I did my first. I was like, yeah, no, just go ahead and bring me the epidural. Will be great. And she's like, okay, well, the doctor's going to come in to see you in a second. And by that time, I had completely saturated through, my underwear, my pad and everything. And I was like, okay, well, maybe it'll get, this will check up and get better because I did have spotting bleeding through both of my pregnancies, which they just said must be what I do. It wasn't a lot, so I never got upset about it. I'll never forget the look on that woman's face when she came and she lifted up the sheet and she looked down at that Chuck's pad. She said, that's a lot of blood. She put it down, told the nurse I needed a new pad, and was very grateful that I was that person who automatically wanted the epidural, because you could just kind of start seeing
her wheels
her
were
wheels were
turning.
turning as to what was about to go down here. You know, I told them, I was like, okay, well, I want to go pee before we get the epidural. I had a spinal headache from the first one. So the anesthesiologist was like, oh, can I just run in the liter or fluid over the next 30 minutes? And I'm like, yeah, sure, that's fine. So I went and I was like, I'm going to go pee. And they're like, no, don't go pee. I'm like, I'm going to go pee. Like, it's fine. I'm not going to push a baby out in the toilet. Mm-hmm. It's okay. I'm just going to go pee.
It's happened, though. I just want to let you know.
Yes. So I'm like, I went to go pee. I came back. They ran the liter of fluid in. The guy came back and he did my epidural. My husband almost fell on me. Whew, that nurse didn't know to take care of me or him. I'm like, I'm fine. I'm not moving. Like, please make sure he doesn't follow me. He just, the blood from his face when he saw that epidural, he was done. I'm like, go sit down. Go sit down. He didn't want to be that guy. I'm like,
he was that guy, though.
Don't be the guy that falls on your wife. But, I mean, they pulled it all in. They had me all hooked up. Baby was fine, but I was just bleeding. Just to kind of get to the point, they hooked me up. Once the epidural got hooked up, they hung the Pitocin and they cranked it. They said, how do you feel? I'm like, okay. They're like, do you feel it, cramping or anything? I'm like, I feel pressure, but, not pain. And they're like, well, we want to crank it up a little bit more. I'm like, go ahead, open it up. We need, I knew we needed to move this along because of the amount of blood that I was losing. And so the good news is they opened that up. And by the time all of this happened, I mean, by the time I walked into the door of the hospital, it was a little after midnight. And so that, you have to get registered. You have to go through this whole process.
The whole thing, yeah.
I had him at 6:11 in the morning. So that whole thing happened over 6 hours.
I don't think that's too bad.
So, I mean, we kind of,
we're moving along.
Tinkered along. And when they got the epidural and then they, because I wasn't dilated at all, my water never broke. So they kind of had to start, getting this pregnancy going because I was losing too much blood for it to be saved, to be put on bed rest or anything. And the doctor was like, you must have abrupted or something. Something must have happened. And I'm like, okay, I don't know. I don't remember having any pain. I just remember going to bed, getting up, and then having my back hurt. But I didn't do anything. It got worse. And then the whole reason I came to the hospital was just because of the bleeding. It wasn't because of the contractions or anything like that. But they went through, got the whole thing done, sent the placenta off, checked the pathology. They did all this stuff. Everything came back fine. It just happened. They don't know why. And then it was, there was only one other couple that was there at the time that I was having my child. And they had this cute little baby girl that was about 5 pounds, some odd ounces. She was just an adorable little thing. They were the nicest couple. And then they had my child. And there's a big preemie sticker on the little cart that the baby's in with all the stuff and whatnot. And they were like, oh, he's premature. And I'm like, yeah, they're trying to figure it out. And they're like, well, how big is he? And I'm like, 6 pounds, 11 ounces. And they kind of turned and looked at me. And they're like, our child's only 5 pounds, some odd ounces. And we were full term. And I'm like, yeah, I think they're still trying to figure that out because he was a bigger baby.
Yeah.
They just said, look, don't have another one. Don't have another kid. We don't know what happened here. And this all turned out
it was okay, but the next one probably wouldn't be okay.
Right. And so they were like, you have a son, you have a daughter, they're healthy, leave it alone. They kind of had the doctor that was there, we had a very good relationship. So she was very blunt and very open when she's like, look, you just need to be done with this. If you wanted a huge family, you need to look into some other options. And I was just like, wow, I've never had a doctor be quite that blunt, but it really was. I mean, he really didn't have any complications either. I mean, he was, hypoglycemic. I remember the nurse coming in, they were like, we're sorry that we had to give him his first feeding, but his blood sugar was like 30. And like the nurse was apologizing profusely. I think she thought I was going to be upset that, she fed my child first. And I just looked at her and I'm like, well, no, that's what needed to be done to care for her patient, which just happened to be my son. And I understood that. And she's just like, yeah, but he ate an ounce, so he's probably going to throw up all over you.
Oh.
He ate it so fast that they couldn't catch it in time. And she's like, he burped well, but, we usually start off with like 10 to 15 mLs max. And he just doubled that. And I'm just like, okay. So I'll blame her for the size of my son now.
I was about to say, I don't think much has changed since the day he was born to today.
It's her fault. I'm fine that she fed him, but she's the reason that he eats like he does. I'm a firm believer.
He has a healthy appetite for sure.
I'm like, now he's like the biggest, he's like seriously like the biggest kid, but he was a big baby. And then they've gone back, they've looked to see if the dates were wrong. And when I went back in for that checkup, they were just like, no, it wasn't wrong. Like, we'd be happy to say, oh, we missed this, or we missed that, because I don't think that they necessarily want to label somebody as having a preterm child. But no, I'm just like, okay, well, last one, done.
Don't tell me twice.
Amen.
I hear you. The good news is that you were healthy. He is healthy.
Right.
Which is a blessing, because it doesn't always work out that way. So I have 2 children as well. And both were preemies. My daughter was born at 36 weeks, and she was 4 pounds, 8 ounces. And she looked like a baby doll because she was so small in her cute little frilly dresses. I ended up delivering early with her because of early preeclampsia. I was induced, delivered vaginally, no epidural. Looking back, probably didn't need one. She was only 4 pounds, 8 ounces.
Whatever. Like,
no judgment.
No. Like, are you kidding me? I'm like, they're like, oh, it's a small baby. Like, are you pushing it out? No.
No judgment whatsoever. Like, for reals, none. For some reason, I guess that experience since I was young kind of like scared me into having a second one. So I like really did plan my son. And my children are like 9.5 years apart, share the same, father, all that good stuff. So I didn't think I would have any more complication than the first one. I think I knew I was pregnant before I even realized that I missed my period, because I just didn't feel well. I had that feeling of malaise. Just couldn't put my finger on it, but you knew something wasn't right.
Right.
When I did figure out, okay, I did miss my period, I was like, okay, I need to go to the doctor because I don't feel good. Something's not right. And so I went to the doctor. They did the blood tests. I was pregnant, was ecstatic because at that point we had been trying for over a year.
Right.
And then I remember spotting and bleeding. And I had literally just moved to the Tidewater area, and I wasn't really familiar with anyone. And I had lived in an apartment and made friends with the girl upstairs. And she drove me to the hospital because I could not drive myself. I had they called it like a spontaneous abortion. And they told me that I was on the edge of having that happen to this pregnancy if I did not do complete and full bed rest. And I was like, okay, I can do that.
And how far into your pregnancy at that point?
I was still in like the first trimester. I called my mom. I called my dad because they still lived, in the city where I was raised, I guess you can say. And I was like, Mom, I think I might need you, to come up here and help me with my daughter, because she still had to go to school. She still had, stuff that I physically couldn't help her with.
Right.
And at that time, my husband worked all the time.
Sure.
So Mom and Dad came, and I spent most of the time like literally in the bed or on the couch. And I wasn't even allowed to take more than 5 minutes to shower. Like, they were very strict on the rules. I couldn't have anything salty, this, that, and the third, whatever. Just woke up one day and I was just like having all this pain. I had headaches. I couldn't situate myself. I was like in the second trimester of my pregnancy, and I was just so uncomfortable, and I had so much pain, and the pain mainly was like on the left side. And no matter how I sat or how I laid down or whatever position I was laying in, it just kind of like made it worse. And I have a high tolerance for pain. So when I'm sitting there bawling and crying, my mom's like, okay, something's not right.
Right.
So my husband takes me to see the OBGYN. I couldn't get in with the physician, so I saw the physician assistant. They're taking my blood pressure, it's high. They're telling me, I think maybe we should go ahead and admit you. And I'm like, let's do whatever we have to do. I'm in so much freaking pain. Like it
You
hurt
couldn't
to
even
breathe.
argue.
Yeah, I was like, people know that I argue, but I was like in so much pain I couldn't even argue. I was like, sister, we got to do whatever we got to do because this is awful. And she wanted to admit me. She had said that she thought I had a condition called HELP syndrome. And so when she went to the, I guess, supervising physician and said, this is her symptoms, this is what I believe it is, the doctor didn't believe her. So they didn't end up admitting me. I went home and suffered a little bit more. And then it got to the point where I went back to the emergency room. My blood pressure was even worse. They did one of those 24-hour urine collections looking for proteins and things like that.
Right.
Determined that I did have preeclampsia, and it was pretty bad, but they couldn't figure out why all the other things were happening. So they took me from Chesapeake General to Norfolk Centera because at that time, Chesapeake didn't deliver children or babies under 37 weeks. So you automatically got sent to Norfolk.
Right.
Because they had a preemie NICU. So it ended up that I had preeclampsia.
Explain what preeclampsia is.
So it's high blood pressure, and it stresses your heart, and it causes problems during pregnancy because you can have a stroke, you can have a heart attack, you can die from it. It's a problem during pregnancy, but then after you have a child, it can be treated. It doesn't automatically go away. You have to be observed for a little while to make sure that you don't stroke post-baby.
When a woman does get pregnant, our blood volume increases. And so we have more
fluid to
push through around to compensate, to help with the child.
I was the guinea pig in this. I had several doctors. I had residents. It was a teaching facility. Like everybody was trying to figure out what was wrong. And when they finally did figure out what was wrong, they figured out that that physician assistant, whom was kind of like glanced over, was right. I did have HELP syndrome. And HELP syndrome is a pregnancy complication that affects the blood in the liver. It breaks down the red blood cells, and we all know that red blood cells carry oxygen from your lungs to the rest of your body.
Right.
It also elevates your liver enzymes. High levels of chemicals in your blood give you liver problems, and it also lowers your platelet count. So the pain that I was having on my side was actually my liver swelling.
Right.
That's the pain that I was having.
So HELP is HELLP. The H being for the hemolysis, the EL for the elevated liver, and the LP for low platelets.
And platelets are the little pieces in your blood cells that help your blood to clot. And a low platelet count can lead to serious bleeding, hemorrhaging. It is rare. It happens in about 1 to 2 of 1,000 pregnancies, and it usually develops in the 3rd trimester of pregnancy, but it sometimes develops in the week after a baby is born. So you can have this during pregnancy and post.
So I wonder if this started at the beginning of your pregnancy because of your fatigue and your malaise. If you think about what the role of red blood cells are doing, they're delivering nutrients and oxygen. And if your body's not getting what it needs, then you're gonna feel bad. I mean, that's why people with anemia, they're tired, they're sluggish, they can be short of breath, and all those things happen because they don't have enough red blood cells, and we give them packed red blood cells to help make them
Yeah, I would
feel
think.
better. So I wonder if it just happened sooner in this pregnancy with you, and it wasn't until later on that it really escalated to the point to where it caused the severe pain and made you
Yeah.
seek treatment.
Yeah, I mean, the last pregnancy compared to the first pregnancy, it was just totally different. It was just absolutely totally different. And, without early treatment or without this being diagnosed while pregnant, 25% of women who have HELP syndrome have serious complications. And without treatment, they can even die.
Well, yeah, I can absolutely see that.
So I mean, I was in my feelings for a little while with my OBGYN physician who kind of just glanced over the PA's correct diagnosis. I was in my feelings for a long while about that.
Well, if you're not examining the patient and somebody's coming to you saying that they think that there's a serious condition, then maybe you need to like walk in and see the patient before you say, no, it's not that. Just that's so
Yeah.
rare, you're not going to even see that, which is probably what he or she
Hmm.
thought was that,
Hmm.
oh, that's
It's
rare.
so rare. You'll
You,
never see that. And then, of course, I was the guinea pig. I was the unicorn and the guinea pig in
you
this
want it to be
situation.
special.
So, one of the risk factors for HELP is having preeclampsia
Mm-hmm.
or eclampsia, which I had in my first pregnancy and I had in this pregnancy.
Mm-hmm.
And about 1 to 2 in 10 pregnant women, or up to 20%, who have preeclampsia also develop HELP syndrome. And I think that's important because honestly, I didn't even know that that was a risk factor of me have developed HELP syndrome through my pregnancy. And some of the signs and symptoms of HELP syndrome are blurry vision, chest pain, or pain in the upper right or middle part of the belly, which I had,
Right.
and headache and fatigue and not feeling well, which I had, nausea. I was always nauseated, but I never threw up. I'm probably the world's worst vomiter. Like, I know it would make me feel better if I did it, but I was just one of those who didn't want to go through the action of doing it.
Yeah.
So it made myself worse by keeping it in. That's the kind of person I am. I did gain a lot of weight quickly and I swelled up during this pregnancy. One of the symptoms is nosebleeds that don't stop, but I didn't have that. And seizures are rare, but if this syndrome is not treated, it can lead up to that. It can cause bleeding and blood clotting problems. It can build up fluid in the lungs. It can cause kidney failure, liver hemorrhage, and placental abruption. There is treatment for HELP. In my case, I was bedridden in to the hospital. I was unfortunately put on medication, was taking Dilaudid for the pain because we were trying to save the baby.
Right.
And, trying to develop the lungs, develop everything before the baby came. Even with all that help, of trying to have him delivered after 29 weeks. We didn't quite make it that far. We made it at 29 weeks.
Mm-hmm.
He was 2 pounds, 12 ounces, very tiny thing.
Mm-hmm.
The doctors just couldn't figure out why it breast so quickly. I don't know why either.
I wonder if you would have gotten the treatment that you needed when that physician assistant wanted to treat you and admit you, if it would have helped, because we know that early intervention is key a lot of the times. I don't know enough about this syndrome to know about it. I know when you first told me about it, I was like, what's that?
Yeah,
I didn't
don't
know
think it's
about
very
it.
common. Well, and it's not very common. Like I said, I guess I was the unicorn and the guinea pig for those doctors because when they first saw me, they didn't know what the hell was going on.
Right.
They were just like, whatever, you are dying and this baby is dying and we've got to figure out a way for their concern
They're
was
going
for
through
me.
Yeah, they're just going through treating
Yeah.
the symptoms as much as they can.
I remember the physician at Chesapeake General saying, well, my concern is you're my patient. So I have to make sure you're alive. And I remember her comment and her saying, you can always have more children. I was in my feelings about that too.
Yeah, I know you guys can't see me, but my eyebrows just went up because
I was in my feelings about that too. So I was not upset when I had to ride in the ambulance from Chesapeake to Norfolk at all.
No,
I wasn't in my feelings. So treatment of HELP, if you have it, you definitely need to give your provider a call, let them know what's going on, because you're going to need medication to control blood pressure and to prevent seizures. In my case, I needed a blood transfusion during delivery. I had no platelets. My arms, from being stuck so many times and having blood draws so many times, I looked like I had been dragged behind a semi truck. It was awful. It was awful. I had to have a PICC line put in because they couldn't draw anything from anywhere at that point.
That's rough.
Of course, I had to deliver as soon as possible because we were both dying at that point. And, anything before 37 weeks is considered preterm. And there are complications for the mother and a child who's born with or from HELLP syndrome. And I had to be given, steroid shots to speed up his lung growth because he was so tiny. I also had to deliver through cesarean section, C-section, because I needed a blood transfusion and he needed out as much as I needed him out, or we both would have died. I'm very thankful and grateful for those physicians at Norfolk General who finally were able to save my life.
Right.
I was told that I should not ever have children and that I should never, ever have children with whom is now my ex-husband. So it all ended up working out. I do remember, that first year of having a preemie, especially a preemie that was that small. He had jaundice. He was on a ventilator. He stayed in the NICU for 6 weeks. He was only able to come home after he was finally able to successfully eat and pass his car seat test.
Yes, I remember the car seat test.
Because every time they had tried before, he would have like an apnea. The car ride home is 30 minutes, so they have to test the baby for as long as the ride home is. So anyway, he finally passed his car seat test, and we were able to bring him home at 6 weeks. But let me tell you, that first year was hard. Before I left the hospital, they told me my baby was going to be blind and deaf. I was getting mail at the house before I even left the hospital telling me about the school of the deaf and the blind.
Wow.
Like, it was a lot. I was told if I didn't take my son to his follow-up appointments, his eye appointments, his hearing checkups, his regular pediatric checkups, that they would call CPS on me and report me for neglect. They were very serious. That first year was rough.
It's sad that they have to do that with children that are premature, especially to that extent. But at that time, the shift goes from mom to the child, and their
concern is for the child because that's a patient too.
Absolutely.
I think because of the area that I delivered in, it's not necessarily the best area. And I think maybe they had a lot of preconceived notions because some of them had insinuated, did you do drugs when you were pregnant and this, that, and the third? Because my son was, born with some withdrawal symptoms because I was medicated from HELLP syndrome and from the pain. So he was also withdrawing from Dilaudid.
Right.
Because that's what I was given. But it was either that or like stroke out. Like after delivery, I was on magnesium for like 3 days. My baby was born. I didn't even get to meet him, not even, physically for days later. I had pictures. And even then I was like, I've always been a little paranoid, but I was like, this is not my baby. This baby doesn't look anything like me. It's like, I don't know what you did with my child, but you need to get me the correct child because this child has red hair. And blue eyes, and none of us here have red hair and blue eyes.
Right.
And she was looking at me like, I swear to God, it's your baby. I would never do anything like that. And I'm like, I want to see my baby now because this is not my baby. And she was like, you can't go anywhere because you're on mag and you're a fall risk. And I was like, this is not my baby.
You better get a wheelchair.
I need to speak to somebody right now because this is not my baby. I go in there and finally see him, and he's like next to a baby who had, was it gestational diabetes? So he was he was an 11-pounder right beside a 2-pounder, and I was like,
the reality of how small he is hits you real fast.
I don't think people realize sometimes how hard it is just to conceive, let alone to be born, and it's a struggle.
It really is. I have a nephew that was born at about that same time frame that spent the whole, we did the whole NICU thing, and that was because my sister-in-law, she went into preeclampsia, and he is deaf, and it is sad because there's a lot of ins and outs, but when you look at how small they are and all these tubes and wires coming out of them, it just breaks your heart.
It does. You can't touch them for a certain amount of time, and you have to transition into it. And I'm very grateful for those NICU nurses. To be honest, I know we talked about this on an episode before. It was that LPN in there that was taking care of my son. And I remember asking her, what is an LPN and why are you in the NICU?
Right.
I mean, she's a lot of the reason besides my father as to why I'm a nurse today.
Right.
And I appreciate her. I appreciate her so much. As I was kind of like saying before with the whole CPS, and they are going to call me for neglect and this and that, and how they used to have, or probably still have a lot of babies who are born prematurely because of drug use.
Right.
I think they had clumped me into that category, even though my paperwork had said all different. It was every question that I ever had to answer for over a year of follow-up appointments and visits. I want to kind of touch on some of the disparities and why in a technically advanced nation such as the United States, why it is so hard to, 1, conceive, 2, be born, and 3, for mothers to survive birth.
Right. We had touched on this subject before in one of our previous episodes, which actually made me want to, pull some more information. Because I did find it astonishing about some of the disparities with Black women and childbirth. The maternal death rate for Black women is 37 per 100,000 live births. That's 3 times the rate of white or Hispanic women.
That's incredible.
It's just kind of crazy. And instead of working to lower that, there are certain cities where that number has risen another 12%. That's crazy.
It's insane.
We're going the wrong way for maternal deaths here.
And I don't understand why it's so difficult in the United States with all the technical advancements. We're not a third world country. No. I would not be surprised had I heard these numbers and it was from, a deprived country, but we're not deprived.
We're not.
But for some reason, our health care is deprived.
Right. American Indian or Alaskan Natives and Black women are 2 to 3 times as likely to die from pregnancy-related births than white women. So that's a high number. I mean, 2 to 3 times more likely.
50 to 75 times more likely. 75% more likely.
Something that you have to look at. Black women fared worse, dying 2.5 times more often than white women, while Hispanic women had the lowest rate of maternal mortality. And then we have some statistics in there. We'll put those on our website. We've got to figure out what we're doing to even that playing field and find out why. Why is this occurring? You have to recognize it first.
Absolutely.
And then once you recognize it, then you can work on a solution. Black women have historically had the highest maternal mortality rates. They think this is because of pretty much racism in society, just to put it out there as bluntly as we can, that there are incidences where Black women do have increased risk for certain health conditions such as obesity and hypertension. But they are also stating that Black women have less access to quality prenatal care. And
I think that's a key word there, quality.
Right. And so if you're not getting good prenatal care or getting prenatal care at all, for whatever reason, whether it's a trust issue or an educational issue,
a financial issue,
right,
embarrassment or shame issue, it could be many things.
We just have to, in my mind, make good quality programs available in places where we know that these maternal death rates are higher.
Mm-hmm.
To me, that seems, and I know it's easy to say that out loud. You still have to have people who are good, willing to go and give the good care. And there are going to be patients, no matter what you do, who are not going to listen to providers.
Mm-hmm.
So there's no way to make these numbers zero.
It will never be zero.
And I understand that, but it should be more even.
Equal, absolutely. Absolutely, I believe that. It's going to be a crisis. The high rate at which Black mothers are dying during or after childbirth. I mean, this is real.
Especially if it's rising.
Exactly. So in order to reduce the disparities in pregnancy-related mortalities, I agree with everything that you said. Absolutely. And reducing disparities will require, the participation of multiple systems. And we need to address these factors, and we need to address how these factors affect disparities. And studies from the NIH suggest that the quality of healthcare from preconception through postpartum care may be critical for improving outcomes for racial and ethnic minority women. And research has demonstrated that nearly half of the severe maternal morbidity events and maternal death are preventable. 84% of physicians studied agreed that disparities impact their practice, but only 29% of them believed that their personal bias affected how they cared for their patients. So we're not even recognizing our own biases and the work that we're doing every day. Right. And it has to start with you. Like, you have to sit down. And I know we've talked about this before in previous episodes.
Absolutely.
You have to sit down and ask yourself, did I treat all my patients who have all the same health conditions the same? Did I offer them the same education? Did I offer them the same treatments?
And I like to say this because I can give 3 people the exact same handout and say that I gave my 3 patients who all have hypertension. Say I have 3 patients. Say one is somebody like me. I have college education. I'm white. I'm a nurse. I have a background. I'm a normal everyday person. I'm not anybody extraordinary. You give me a handout on hypertension. Mm-hmm. Okay. Then you give somebody that's just like me, and let's call them Hispanic. Mm-hmm. They are educated, same level of education, but English is not their first language. But you gave them the same handout. Okay. Now we're going to put a third person in there. We're going to use black, just so we use the color of the rainbow, right? Mm-hmm. We're going to go light to dark. So we're going to give a black woman, say she has the same level of education, but she was raised in a family where there was no emphasis on care. Mm-hmm. But you didn't ask her about that. So all you know is that there's a couple of people here that say we're all nurses or whatever, or all have some education, or none of us are nurses, but we all have maybe, say, this 2 years of college education. Say we all have like an associate's degree. A lot of people are graduating high school now with that. So we'll go with that. If you didn't take into consideration somebody's socioeconomic background, like you didn't take into consideration to give this Hispanic woman this handout in Spanish, and you didn't talk to this African-American woman about the fact that maybe you understand that in some African-American families, prenatal care is not as heavily emphasized. Mm-hmm. But you find it to be very important and go that extra mile. You did not give us the same information.
No, we're not all the
same. You gave us
the same person.
You gave us the same handout, but you did not give us the same information.
No.
And I think part of what we do is we say that we gave that person that. I gave them a handout. I gave my same handout to everybody. Well, that doesn't mean anything if one person can't read.
You're absolutely right. I agree with you wholeheartedly.
And so I think part of where our disparities come in is from people thinking that just because they did something,
the bare minimum,
that they've treated everybody the same. But you gave me an advantage that you didn't give to these others. And, people can say all day long, well, it's their job to say, hey, do you have this in Spanish? Or, hey, my family doesn't believe in prenatal care. Because there are different, I am learning as a white person and the way that I grew up. And I have friends that are African American who say, no, we don't really work like that as a community. I'm like, what do you mean? I've had a lady tell me who was a Black woman. We're the same age. We have the same level of education. She's an LPN. And she told me one time, she's like, well, actually, that's really not how things work in the Black community. And I'm like, well, I don't understand. And she's like, well, no, you're not going to. You're white.
Mm-hmm.
And I'm not stupid.
Not at all.
But you have to understand the differences in people's cultures and communities and socioeconomic status, and then give them the proper information.
Well, our jobs as nurses are to educate and not, excuse my French, half-ass. Your example of handing that pamphlet to those 3 different people, that to me is like half-assing.
Right. I mean, you did not.
You helped 1 out of 3 patients. There. 1 out of 3 you helped. You didn't help the Hispanic person who can only read or speak or write.
Even if they can read and speak a little bit of English, would they understand the Spanish one better?
Yes.
Well, yeah, if it's their primary language. That'd be like me taking 5 years of Spanish, being able to speak and understand it, but you handed me a Spanish pamphlet and telling me, here you go, and you handing that to somebody who actually speaks Spanish and grew up with it. Mm-hmm. Who's going to have the advantage?
Why would I hand you a Spanish pamphlet, Ashley?
Right.
What is that? What's that going to do for you?
Right at this moment, nothing.
Okay.
I'm going to look at the pictures. I ain't going to even lie.
I hope they're pretty.
Well, I mean, it would be pointless. I would be able to pick out 10% of those words.
I think we just need to do better as human beings, as people, mm-hmm. and treat people equally. This has been a pet peeve of mine.
I wonder if that's where, because there's a big difference between 84% of physicians stating that they believe that there are disparities. Mm-hmm. 84% of physicians saying, yeah, we know this is a problem and we see it. Mm-hmm. But 29% being like, oh, yeah, I'm part of that problem. Well, you know something? I'd rather go see one of those 29% of people that actually are aware that they may be having personal bias or they've had personal bias in the past, because they're going to be the first ones to fix it.
Absolutely. They're not in denial. So we have to, as Michael Jackson would say, look at the man in the mirror and start there first.
Right. I don't want to think that anybody in the healthcare field would actually have a thought process to be biased. That's just crazy to me. But you have to start looking at bias in a different way.
Mm-hmm. Well, and this is like a whole another topic or subject, so I'm going to make this very short. A lot of this is programmed into us after birth and in school.
Yeah.
So if you don't even know that a problem exists, you have no reason to change what you don't think is broken. So really, and I know I've probably said this 50 million thousand times, the education really does need to start at home and about equality, mm-hmm. not about anything else. Inclusion and equality.
Right.
Period. So hospitals in the healthcare system, they have to implement standardized protocols to help with quality improvement initiatives, especially among facilities that serve the disproportionate communities. Right? And they have to be able to identify and address the implicit bias in healthcare that would likely improve patient-provider interactions, health communications, and health outcomes. And this is really all we want. We're trying to bring this to the forefront because it is important and we know what's going on. And I think this year, out of all the years that I've ever been a nurse, it's been more recognized.
Yeah,
it's
absolutely.
great that it's being recognized. But now that we recognize it, let's start doing something about it.
Right.
And according to Dr. Michael Liu, who's the dean of the School of Public Health at the University of California, Berkeley, believes maternal mortality can be cut in half by 2025 and eradicate maternal deaths by 2050 by doing 3 simple things.
Okay.
He believes you should learn from every maternal death. You should assure quality and safety of maternity care for all women. and to improve women's health across their life span and course. And as mothers and mothers-to-be, we need to make sure that you're maintaining healthy diets and weights, and you're physically active, that you're not using or abusing any substances, that you're preventing injuries and addressing your health problems and concerns, not just during pregnancy, but even before you think about getting pregnant.
Oh, absolutely.
I don't know any physician who won't tell you, if you're thinking about getting pregnant, go ahead and start taking that folic acid, because that's going to decrease your chances of your child having cerebral palsy. So it's very important to not just say, oh, I want to have a baby, but go talk to your doctor about having that baby.
Right. What do you need to be doing to your body ahead of time to give you and your child the best possible chance at a good, healthy pregnancy and delivery?
Absolutely. You want to make sure you're, going to your OBGYN visits when they're recommended and scheduled, and that you're discussing with them everything that you're thinking about. Any question that you have, that's their job.
Absolutely.
That's what they're there for.
That's
their whole purpose.
Something I tell my family, because it's a pet peeve of mine, is they'll say, well, I didn't think it was important to tell the doctor that. That drives me bananas. It drives me up the wall. They don't want to ask because they don't want to seem stupid, or they didn't think it was important, so they left it out. I'm like, it's not your call to make, because you're not a doctor or a provider.
Yeah.
So I'd rather you say, does this have anything to do with what we're doing today? And if they say no, fine, great, leave it alone. But if they say, oh, wow, yeah, I'm glad you told me that, well, then all of a sudden you might completely change the course of their thought process, and they need to backtrack and go at a completely different angle, especially if you're being worked up for something or trying to figure something out. You go to the doctor. Okay, well, if your daughter gets pregnant, she might want to say, hey,
I was premature.
My
brother was premature. My mom had preeclampsia and help. What are my risks?
Right. But they might look at her and say, you're young, you're healthy, you want to have a baby, fine, start taking your prenatal vitamins. But if she goes, well, why do they need to know about my mom? That's not important. Well, it actually is. But if she doesn't know that it's important and she just decides to leave it out because she doesn't think it's important, and then she has a premature child and has to go through all this, then it's going to be a whole different thing. Yeah. And so that's where you really want to make sure that you're explaining everything.
Education is so key in everything that we do, especially in nursing. It's so important to make sure that you're receiving the appropriate medical advice and care. And, that will hopefully help having a healthy pregnancy. We're going to list some resources to this episode on our website. One's something that really struck me, but I know we're kind of stretching for time here, is called the Abundant Birth Project. And it's about pregnancy and supplementation programs for income for those women who are pregnant and don't have the resources. And then I also wanted to, put a link on one of my favorite organizations, which is March of Dimes. I used to be an ambassador family for them a lot of years back. So March of Dimes will always have a special place in my heart.
Sure. Of course, we will list the rest of our references and our show notes from today on our website, thenursingpostpodcast.com. We would love for you guys to join the conversation by leaving your comments on our website or on our social media platforms. Do not forget to subscribe to our podcast, and thank you again for listening to The Nursing Post.